Hi, welcome to our presentation. We are Central Group 1, and we're going to take some time and introduce ourselves. My name is Eleanor Anthony. I live in South Central Kansas. This is my third semester at Ball State. Hopefully, I will sit for my boards next August. Fingers crossed. I currently work at a very ABA agency. We service counties within 190 miles of us. So I've been doing this for 3 years, and my current title is therapist supervisor, and I really enjoy it, but I really can't wait to be finished with the program. So now I'm going to let Naomi tell you about her.
Hello, I am Naomi, and this is also my third semester at Ball State in the ABA program. I live in Chicago, Illinois, and I am now a full-time grad student, which I am enjoying being able to focus or devote more of my time to studies. I was previously working in business, and this is very different from what I'm doing, so I am really enjoying it and looking forward to also being able to be doing it as a professional full-time. And next, Michaela will tell you about herself.
I'm Michaela. I live close to Baton Rouge, Louisiana, and I work in the clinic where I'm a behavior therapist for. I usually see about 3 to 4 kids a day, and they range from anywhere from 3 to 21. Well, the cutoff's 21, so 20 years old. This is my third semester at Ball State University, and hopefully I can sit for my boards soon. I'll be done with the program at the end of the summer, so hopefully after that I'll be able to sit pretty soon. Megan's turn now.
Hi, I'm Megan, and this is also my third semester at Ball State University in the ABA program. Early childhood special education teacher. I work with students ages 3 through 5 in a self-contained special education classroom. And while I love what I do, I've been doing it for 8 years now. I would really like to pursue my career as a behavior analyst and eventually become a consultant in the school settings, and that's my goal. Pass it on to Melanie.
Thank you, Megan. My name is Melanie Sweeney. This is my second semester here at Ball State University. I currently live in Illinois, in a small town called Schaumburg. I work in an ABA clinic in Arlington Heights. I've been there for almost 2.5 years, and I just absolutely love it, and I cannot wait to get my BCBA so I can further help kiddos. Now, Eleanor, please take it away.
Okay, so our group decided to pick a study on decreasing nervous habits during public speaking. We picked this because it's something we all struggle with. It's something a lot of people struggle with, and it's something that we're all going to need in our future careers, whether we stay doing ABA or we go to other fields. So effective public speaking is a great skill to apply in any arena. However, public speaking is also very difficult for many people. It is an extremely difficult task to accomplish. Anxiety often impedes communication, and nervous habits can form and make speeches much less effective. Nervous habits are using fillers such as saying and throughout a speech, making noises with the mouth such as clicking your tongue like this, or those kinds of things, and using the word like where it has no natural belonging in a sentence, such as saying I went to the beach, that has no appropriate place in a sentence, but saying something like, I like bananas, is completely appropriate. Nervous habits make speaking more difficult and make what the speaker is trying to convey far less effective. Several studies have been completed to monitor the effects of intervention on anxiety and nervous habits when speaking in public. In 1994, Kondo identified 6 categories of coping skills, such as breathing techniques, relaxation techniques, and accepting the instance of having to speak in front of an audience and just doing it. Wallach, Safir, and Bars V in 2010 conducted a study using virtual reality cognitive behavior therapy, in which the participants wore a virtual reality mask and were given a pre-prepared speech to present in front of a virtual audience. The therapy was effective, but due to its short length, its inability to be generalized, and the fact that most people don't have access to virtual reality, limited how effective it could really be. Mancuso and Miltenberger in 2016 did a study on habit reversal training. Habit reversal training used awareness training, which is making the participant aware of the behaviors they're engaging in, and then implemented a competing response so the nervous habit could not be engaged in, which included things like pushing their tongue towards their teeth so they could not click it, and thinking in their head of other things so they did not say the word and It also was deemed effective, but there was no generalization over settings. Another habit reversal study was done earlier in 1996 by Woods, Miltenberger, and Limley, and it was found to be effective in reducing nervous tics in children, which is different from nervous habits in public speaking, but the interventions are the same. It was an effective study, but the noncompliance of the children was seen as a limitation. Miltenberger and Fuqua in 1985 conducted a contingent and non-contingent response intervention study on reducing nervous habits. It was deemed effective, but was limited because it was self-recorded. In 2017, Spieler and Miltenberger conducted a study using awareness training to decrease nervous habits, which again is making the participant aware of the nervous habits they are engaging in. This study was deemed effective, but limited because it consisted of unplanned speeches and no generalization. This is also the study that we replicated in our project. Overall, awareness training and habit reversal training appear to be the most effective interventions for decreasing nervous habits during public speaking. For people who have anxiety and difficulty with speaking in front of audiences, one or both of these interventions could be successful in decreasing those nervous habits and anxiety. And now I'm going to let Megan tell you more about the project we conducted.
Sure. So I'm going to go over the purpose of the study. The purpose of the study was to decrease nervous habits while engaging in public speaking. Nervous habits can be described as using fillers, such as or using like when it does not have a natural place in the sentence, and tongue clicking. Public speaking is an important part of various occupations, and individuals need to be professional while engaging in this activity. Group members utilize the methods used in the Spieler and Miltenberger 2017 study to decrease nervous habits while public speaking. Now I will go over the participants of the study. The participants of this study were the members of our group: Eleanor, Naomi, Michaela, Megan, myself, and Melanie. IOA, Eleanor and Melanie also acted as the IOA. The setting in the study was conducted in participants' homes using Google Hangouts. The participants delivered speeches electronically, and the IOA observed all speeches. Materials needed for the study included a computer that was capable of capturing video and audio, a speech for each member to give, data sheets to effectively track the nervous habits while public speaking, a timer, and a questionnaire that was completed both during baseline and then during post-awareness training regarding the participants' beliefs on their comfortableness and ease of public speaking. The operational definition of the target behavior is any instance of the speaker engaging in filled pauses, tongue clicks, or inappropriate uses of the word like. A filled pause is defined as any occurrence of a speech sound or word, such as or that has no semantic meaning in the sentence and was scored only upon the ending of each speech sound. Tongue clicks were defined as the speaker emitting a click sound and were scored upon the distinct ending of each click sound. Likes are defined as any occurrence of the word like in speech that did not follow proper semantic, grammatical, nor syntactical form. This definition could include the speaker saying like before describing what someone said. Example, she was like, I need to leave. Or saying like before describing an approximation of a number, size, event, feeling, or cognition. Example, I had like 16 assignments. This definition did not include the speaker saying like to express interest. Example, I like popcorn, or similarity between two items. Example, I am a lot like her sister. Now I will define the data collection system. The principal investigator collected data on the occurrences of the target behavior listed above. They did so by the usage of video recordings. The data collection used was frequency within 15-second interval recordings during speeches. The data collection system was a multiple baseline across participants. Now I will talk about the baseline. The baseline procedure for the replication project. Each participant had to choose a speech, a topic. So these included things such as first job, first pet, favorite vacation, and favorite holidays. There were 3 participants, including 1 principal investigator, focused on improving public speaking skills. Each participant delivered a speech via Google Hangouts, and the principal investor collected data on the occurrence of the target behaviors of filled pauses, tongue clicks, and likes throughout the speech. The participants would choose a topic to speak about, and then the principal investigator would ensure that no topics were the same. The principal investigator timed the participants, and they got 10 minutes to prepare for their speech. The speeches were not fully written, but each participant was allowed to use a little index card with notes to refer to throughout the speech. Once the 10 minutes were up, the principal investigator would let the participants know. Participants were also able to decide if they were ready before the 10 minutes, and they didn't have to use all 10 minutes. The participant was instructed by the principal investigator to deliver their speech, and there were no other participants. It was via Google Hangouts, so it was recorded by video. The principal investigator would provide a countdown for the participant to begin the speech. It was 3, 2, 1, start. The principal investigator would turn on a recording device and set a timer for 5 minutes, as each speech had to be 3 to 5 minutes. The participant would begin their speech, and then the principal investigator would prompt the participant to continue with their speech if they stop it for more than 15 seconds or stopped before the minimum of 3 minutes. During the speeches, the principal investigator maintained a neutral facial expression, and they did not provide any feedback to the participant during the speech or after the speech was concluded. When there was 1 minute remaining, the principal investigator would hold up a blank white card And then if they were going over, the principal investigator would hold up a blank red card when 5 minutes was done. The video recorder was turned off when the timer went off, and then after the participants concluded their speeches, the principal investigator took data on the video recordings using the 15-second interval to record frequency of the separate behaviors. Now I'm going to turn it over to Melanie.
Thank you, Megan. Now, the second phase of the procedure was the awareness training. During awareness training phase, investigators implemented the response description and response detection components of awareness training in the context of a speech delivered by the participant. Response description involved a discussion about each participant's behavior that were targeted for reduction, including their unique operational definitions. Investigators then showed the participants a video from the recorded baseline sessions and identified occurrences of each target behavior. This step was response detection. The participant then chose a topic on which to speak and prepared it for 10 minutes as she did in baseline. During the speech delivery, the participant raised her right hand contingent on the occurrence of a target behavior. Investigator also raised her right hand contingent on the occurrence of a target behavior throughout the beginning of the speech. After the first 5 behaviors, investigators only raised her hand to prompt the participant if she failed to detect an occurrence of a target behavior within 2 seconds. The participant delivered a speech on the same topic until 100% of the target behavior were correctly identified in one presentation, or until 90% were identified across 2 consecutive presentations. Awareness training was terminated upon meeting this criterion, or after the participant exhibited little to no improvement in identifying his or her behaviors after 3 consecutive speeches. Now I'm going to be talking about the post-awareness training assessment. Now, the sequence of the procedures for the post-awareness training assessments were the same as baseline. So now I'm going to be talking about the booster session phase. Now, while there were no participants in this replication study that required any booster sessions, these booster sessions were required had any participant not decreased their nervous habits by 80% during the first post-awareness training assessment to that of their baseline levels. Now I will be talking about the generality probes. Now, one generality probe per participant was conducted in this study. Generality probes occurred following the participant's final post-intervention assessment. Now, participants were given a choice between 2 novel speeches, chosen from the same list as Megan described, that they were not previously presented. Speech procedures were identical to those described in baseline. However, an audience of 4 individuals, 1 investigator, and 3 other individuals from the group were assembled for the speech delivery. The audience members varied in age and ethnicity. The audience was instructed to refrain from providing feedback to the participant during and after the speech. Now I will be talking about IOA. Now, the Inter-Observer Agreement, which is IOA. A second investigator also collected data on the target behaviors. All investigators were trained to correctly and reliably identify occurrences of the target behaviors using baseline videos of the participants. The IOA was calculated for 33 to 36% of sessions across participants. The number of occurrences of the target behaviors recorded by two independent data collectors were compared. The mean IOA across participants and phases was 94%. So the mean agreement was 94% for Naomi, while the range was 77% to 100%. For Eleanor, the mean agreement was 98%, while the range was 84% to 100%. For Megan, the mean agreement was 85%, while the range was 57% to 100%. For me, Melanie, the mean agreement was 89%, while the range was 75% to 100%. And for Michaela, the mean agreement was 86%, while the range was 62% to 100%. Now I will be talking about the treatment fidelity. Data on the treatment fidelity were calculated for at least 33% of sessions in each phase of this study. Investigators watched sessions from each phase of the study and scored implementation steps. So the steps for each list were scored as for a yes. Then they were divided by the total number of steps for each list, which yielded a percentage of treatment fidelity. Items scored as not applicable were not included in the total number of implementation steps. Treatment fidelity was 100% across all phases and participants. Now, Naomi will tell you about the results.
Okay, I am going to take you through results, and I have a couple graphs and figures I'm going to take you through. On the current slide up, I have the graph results from each participant in their baseline and intervention. The effects of awareness training on the rate of habit behaviors on all 5 of us as participants are shown here in this figure, and we all exhibited a decrease in target behaviors in post-awareness training assessments. Eleanor's habit behaviors in baseline averaged 7.2 per minute and decreased to an average of 0 per minute in post-awareness training assessment. Naomi's habit behaviors, myself, in baseline averaged 10.4 per minute and then decreased to an average of 2.25 per minute in post-awareness training assessment, ranging from 2 to 3 per minute. Michaela's habit behaviors in baseline averaged 8.5 per minute and decreased to an average of 1.66 per minute in post-awareness training assessment, ranging from 0 to 3 per minute. Megan's habit behaviors in baseline averaged 6.75 per minute and then decreased to an average of 0.33 per minute in post-awareness training assessment, ranging from 0 to 1 per minute. Melanie's habit behaviors in baseline averaged 5.4 per minute and decreased to an average of 0.5 per minute in post-awareness training assessment, ranging 0.3 per minute. In both baseline and in post-awareness training assessments, was the highest frequency filler used by all participants engaging in filled pauses. And there were no participants that engaged in tongue clicks. On this next slide, I will show you all the results of the questionnaire that all participants took at the end of the replicated study. It goes through, as you can see, there's a category for comfort level, overall ability, confidence level. It goes through baseline and just overall public speaking abilities and confidence, and you would rate yourself under each of these categories. So I'll take you each through them. In this questionnaire, regarding all of our public speaking abilities and confidence, participants recorded improved scores across almost all measures. The table here shows the average scores for comfort level improved by 2.2 points. Overall ability improved by 2.3 points. Confidence level improved by 2.2 points. Overall ability by 2.3, I'm sorry, I think I looked at it wrong there. The average scores for comfort level were 2.2, overall ability was 2.3, confidence level was 2.5, and the use of fillers improved by 0.9 points. All 5 participants rated their anxiety levels the same in baseline and post-awareness training assessments, resulting in the only category showing no improvement. In the external ratings on the bottom, they indicated that there was improvement across all measures from baseline to post-awareness training assessments. As you can see in this table, comfortable appearance improved by 1.6 points. Eye contact improved by 1.7 points. Voice projection improved by 0.8 points. Out-of-breath appearance improved by 1 point. And use of gestures improved by 0.3 points. Speaking rate, nervous appearance, and use of movements and use of fillers all improved by 0.9 points. The most considerable improvements were confidence, improving at 2.6, overall ability, improving by 2.5 points, and speech fluency, improving by 2.2 points. All participants rated the awareness training procedures favorably and found that the intervention was effective in reducing verbal fillers. I'm now going to pass it along to Michaela, who will take us through the conclusions of our study.
Okay, for the conclusions, the results of our study showed that baseline awareness training and post-awareness training produced significant decreases in the instances of using fillers such as the inappropriate use of the word like, and also the occurrences of clicking one's tongue across all 5 participants while publicly speaking. In the beginning of the study during baseline, numbers showed that all participants had high instances of either one or more of the behaviors listed above. But by the end, decreasing trends were shown. If any of the participants' behaviors did not decrease by 80%, booster sessions were required. After baseline, during awareness training, all participants were required to participate in at least one awareness training session, or however many it took, with their partner to make sure they were aware every time one of their behaviors occurred. Once they both came to an agreement and had their hands raised at every instance of a behavior, they then moved on to the post-awareness training. All post-awareness training sessions showed little to no overlap with their baseline sessions. If overlap was shown, it was only for one data point. Data points went from high to low numbers ranging from 19 to 1, and overlap was marked on 2 occurrences. One being my baseline to post-awareness training overlap of 3, and Megan's baseline to post-awareness overlap being 1. For post-awareness training, behaviors still decreased slightly and stayed below baseline averages. Results from the study showed that the awareness training and post-awareness training is an effective intervention that works based on the self-evaluations that we gave. All participants were more comfortable presenting to one another by the end of post-awareness training. On to the limitations. Some of the limitations of the study that we found were that although the participants got comfortable with the small audience of just our group, there was no generalization to occur to a bigger audience or across settings. Everyone gave their speeches in what was comfortable to them. Another limitation could be the speeches were not required to be a certain length, nor were the speeches required to be long. The duration of our speeches given were at a set time of 3 to 5 minutes, and nobody went over their time. Also, the speeches were all spontaneous to where, once given the topic, each person only had 10 minutes to gather their thoughts. Since the speeches were spontaneous, they were given about personal opinions and did not relate to any specific research topic. And here are our references. Kondo 1994, Strategies for Reducing Public Speaking Anxiety in Japan. Mancuso and Miltenberger, Using Habit Reversal to Decrease Field Pauses in Public Speaking. Miltenberger and Fuqua, A Comparison of Contingent and Non-Contingent Competing Response Practice in the Treatment of Nervous Habits. Spieler, Milton, and Miltenberger, 2017, Using Awareness Training to Decrease Nervous Habits During Public Speaking. Wallach, Safir, and Bars v. 2009, Virtual Reality Cognitive Behavior Therapy for Public Speaking Anxiety. And Woods, Miltenberger, and Lumley, 1996, Sequential Application of Major Habit Reversal to Treat Motor Tics in Children.
All right. Overall, in our study, we really enjoyed going through the replication study. Although we did not master public speaking, the replication study made us way more aware of what we say and how often and frequently we're using our fillers throughout. The study was helpful, provided it's a great tool for us. Public speaking is useful in everyday lives, and it's often expected in many of our professional careers. So as a result of replicating this, we're all very much more aware of our fillers and enjoyed doing so. So thank you all for watching our presentation, and we hope that you enjoyed it.